Wonderful. Good morning and good afternoon to everyone. I'm Dr. Jill Einstein, the Director of Physician Engagement of the Maven Project, and welcome to today's talk on the Safety Net Clinic, Community Health Centers, an overview, past, present, and future. It's my pleasure to welcome today two outstanding people in the field, Melissa Schoen, who is a healthcare consultant, and Dr. Laura Miller, who is the CEO of Community Health Network. And it's really a pleasure to have you here today. The impetus for educating our physician volunteers and our staff came from one of our physician volunteers, Dr. Ed Hattler, who is a retired internist from Kaiser, Northern California. And he was about to embark on mentoring one of our clinic providers and one of the safety net clinics who's our partner. And he said he just wants to understand more. What are the pressures that the Maven clinics are under? What about their feelings about clinical performance and morale? I want to know more about the clinics that we're serving. And then that led me to connect him with one of our physician volunteers, Dr. Jeannie Reisman, who's also a retired internist from Kaiser in Northern California. And she often meets with our newly minted mentors to share her mentoring experiences with Maven and sort of offers herself as a mentor's mentor. And they had a very engaging conversation, and that really inspired Jeannie to say, this is very important for us, the Maven Project volunteers, to learn about the clinics whom we're serving. And so she made this great connection with Dr. Laura Miller and Melissa Schoen, and that brings us to them being able to present to us today. So I'm really appreciative of all of those connections leading to this day. I'd like to turn it over to Maven Project's interim CEO, Howard Kahn, who would like to make some comments and share his perspective. So Howard, I'll turn it over to you.
Thanks, Jill. My comments will be very brief and mostly to express a lot of gratitude. I've been the interim CEO for Maven for about 4.5 months now, and was on the board for the year previous.
Something about community health centers.
And I've had a great experience as the interim CEO, working with our staff, starting to work with some of our volunteers, and mostly I wanted to say thank you to all of you. It's been a great time. We've made a lot of progress as an organization. Our new CEO will be starting in a couple of weeks. We're formalizing the announcement now, but we're very excited about it. I'm really excited because I get to go back into retirement, which is where I belong, and return to my board role. But I wanted to do several things. One is to thank all the volunteers who are joining us today, and particularly to thank Jeannie and Melissa and Laura for doing this presentation. I've worked with community clinics for 35 years, roughly my whole career, in one form or another, and to watch them morph over the last 20 years in particular has been great. My one comment about the community clinics is they're in an interesting position. Both the FQHCs and the free and charitable clinics, but particularly the FQHCs, have been loved by all administrations, whether Democratic or Republican, for different reasons. But they've been in the fortunate position of being supported, and you're going to hear a lot more about that, and growing over the last 25 years from what were very often free clinics that became FQHCs and developed into a whole base for serving people who are really underserved throughout the country. And so I wanted to join in on this again once to say thank you to all of our volunteers and to the presenters today. And I look forward to hearing about the history from Melissa and Laura's perspective. So I'll stop there and say thank you. It's been a pleasure. And Maven's got a great staff too. For those of you that have been working with Jill, you know that already, and with Linez, but it's a great staff throughout the organization right now and ready to work with you. Thanks.
Thank you, Howard. Jeannie, I'll turn it over to you for your introduction of our speakers.
Well, it's really an honor and a privilege to have Dr. Laura Miller and Melissa Schoen here with us today. And I'm just going to review their bios so you really have an appreciation for their background and what they're going to be sharing with us today. So Dr. Laura Miller is the Chief Medical Officer for the Community Health Network, which serves about over 140,000 Medi-Cal eligible folks in Alameda and Contra Costa counties. That's in Northern California in the Bay Area. She has a long history of service to the community, having served as a primary care clinician for the Lifelong Medical Clinic starting in 1999. She received her undergraduate degree from Wesleyan University, majoring in history and Latina American studies, received a Fulbright, which sent her to Ecuador. And her medical degree is received from Harvard Medical School. And she completed her residency training at the University of California, San Francisco. So welcome to Dr. Miller. And Melissa Schoen, who some of us certainly know her father, is a consultant who specializes in improving the scope and quality of healthcare services with those who serve the underserved. She provides expertise in leadership and workforce development, business and operations planning, and organizational transformation. With over 25 years of experience, Melissa has played key roles in the launch and expansion of foundation programs and has overseen operations in varied healthcare organizations, including independent physician associations and, of course, community health centers. Previous positions, just so you have a little bit of an idea of what she's done, Senior Program Officer Innovations for the Underserved Program at the California Healthcare Foundation, and Chief Operating Officer Deputy Director at Lifelong Medical Care. Melissa received her Master's in Business Administration and Master's in Public Health from the University of California at Berkeley, and a bachelor's degree in Organizational Behavior and Psychology from Pitzer College. Thank you both for being here, and I'll pass this along to you both.
Great. So I think I'm up first, Laura. And Laura and I go way back, working together at Lifelong, and I was an administrative person there and she was a clinician, and it was such a pleasure to have Laura as a partner, and now it's so fun to work with her in kind of new ways. So you're going to hear a little bit from me about kind of the overview of health centers, the background, kind of the data about what they do, kind of more the administrative side, and then Laura's going to give you a day in the life of what it's like to be a physician at a health center, close to full time. She's worked there, as you heard, for many years. So I also want to echo what Howard said about the thank you. We really, really, really appreciate everything you do for health centers. They struggle, they're resource strapped. And so you'll hear a little bit more about some of their struggles, but it means so much when we get people that have the experience that you have, the skills that you have, and that you're willing to bring those to the health centers. So let me go, and we have our presentation. So hopefully everybody see that, good? Okay. So we're gonna go a little bit about health centers. And as Howard said, they have a really, really interesting history. So let me just take you through one. Here's a picture in the 60s in the Central Valley of California, where farm workers gathered. And they gathered and started having volunteer physicians, nurses, clinical people helping them. And they would gather at their local little market, kind of the center of town. And that evolved. And so this is in the late 60s, same location. Over 10, 15 years, it actually became a small little clinic. This is a picture in 1979. Family healthcare, I think it was called, actually it had a different name. And I can't remember what the name was, but it was a small clinic, had about a budget of about $290,000, but served lots of farm workers, balance of volunteers, balance of paid staff, and served mainly a migrant farm worker community. And this is Family Healthcare Network, probably about 3, 4, 5 years ago. Almost a $70 million organization, the biggest primary care network in the 2-county area. They serve, I believe, 150,000 patients, and I believe they've still been growing. And the CEO that was there until about 6 or 7 years ago was actually one of the founding CEOs. And so this is not an atypical story of a health center. Grew up from kind of social movement, volunteers, and becomes a multi-million-dollar healthcare organization, often having some of the same staff there over all that time. I worked at 2 different clinics in the Bay Area. Both of them, I worked with the founding CEOs. And so now you see these clinics, they're modern, they're really located in their community. They have high quality, excellent physicians like Dr. Laura Miller. They really are community centers. You can see some of these amazing buildings that they've been able to build, and multi-sites. So that's not, again, not atypical. And so they're really proud of their history, and it's actually called a movement, and people say health center movement. You can see why. So how did it start? Really started in the 60s and early 70s on Johnson's War of Poverty, and really based out of this social justice framework. As I told you, the Family Healthcare Network, right? Migrant workers. Clinics that I worked at were urban centers, neighborhood health centers, really about their communities, and came out of this civil rights movement. You'll get these slides. At the bottom, I put a link. There's a great, it's about a 5-7 minute YouTube video, talks about the history. It came out called out of the Public Health Service Act, called Section 330 of the Public Health Service Act, created these neighborhood health centers, and actually first came out of the Office of Economic Opportunity. And as Howard said, they have since the beginning have had both sides of the aisle supporting them. So the 2 sponsors of this bill were Ted Kennedy and Orrin Hatch. Now, you can't think about that today, those 2 opposite ends of the system, of the Democratic system, coming together to create something. But to this day, they still have support from both sides of the aisle, even now in our current political situation. So, but there are significant federal requirements, and it builds off the history of the health center movement. You have to be located in a federally designated medically underserved area. It's called MUAs. There's also health professional shortage areas, HPSAs. They're federally designated. You have to be located in one of those to be a federally qualified health center. You have to be nonprofit. You have to have board membership that represents the community. So more than half of your board has to be patients that you serve, requirement. You have to provide services to everyone, regardless of ability to pay, and you have to provide the breadth of services. So cradle to grave, as they say, from beginning to end. You have to provide all those services, and you also have to provide comprehensive services, so enabling services. So things like transportation, social services. There's other requirements like that that you have to provide to be designated a federally qualified health center. So you hear them referred to as FQHCs, federally qualified health centers. You hear them referred to as 330s because that's where they get their funding. Again, they have to be nonprofit. They could be public, but nonprofit. And then I already mentioned some of this. You have to be located in a high need area. You have to serve all. You have to have a majority governing board. One other thing on the board. It actually says, and I'm not sure if this is still the case, but it was at about 10 years ago when I was still working at clinics, it limits how many physicians can be on your board because they did not want to be controlled by the mainstream physician healthcare system. So very much wanted to be controlled by the community, and even said, we do not want physicians anywhere near us. We want to be run for ourselves, and we want to be advocates for ourselves to physicians. There are varying kinds, because of the federal government, there are different kinds of designations, and there's one called Federally Qualified Health Center Lookalike, so you may hear that, and they don't get the 330 funding, but they get all the other benefits. So I won't go through all of them, but just do an example. It just starts getting, when you start peeling away the onion of the federal requirements, there's rural health clinics, there's federally qualified lookalikes, there's free clinics, there's all these different kinds of designations. So it gets very complicated. So you may be working with different ones within kind of these federal designation of clinics. FQHCs and FQHC lookalikes, a big thing is you are eligible for enhanced reimbursement under Medicaid and Medicare. So it's called the Prospective Payment System. You may hear this being referred to in your clinic about PPS reimbursement. And what that is, and it's slightly different state to state because it's run through the state Medicaid agencies, but it has to be cost-based reimbursement. So health centers, and it's very complicated. I'm very familiar with it in California, less familiar with it in other states where I think some states are less complicated, some are more. But essentially you have to provide what your costs are. You divide by the number of visits, and that is your per visit cost. And that's what you get to charge Medicaid. Now note that that is only for those patients that come in that are Medicaid covered. Uninsured don't get any reimbursement, right? So there's kind of a cross-funding happening there. So everybody talks about, oh my gosh, they get cost-based reimbursement, but a huge portion of their patients don't get reimbursed at all. So just a little bit of understanding, but that is incredibly important to health centers. But there are huge amounts of regulations around that by the federal government, because the federal government wants to put a really thick wall around that PPS payment so that nobody else is eligible for that. So if you're contracting out with other providers, you don't get to give them the PPS. It gets very complicated, but just note that that's an extremely important part of being an FQHC. You also get very other important things, including FTCA coverage, which is Federal Torts Claims Act, which is malpractice. So the federal government covers malpractice for community health centers, which is amazing because it obviously saves a huge amount of cost. But on the other side, if you can think about the federal government, there are huge amounts of regulations that you have to follow. And a lot of things get really complicated, like credentialing and things like that, that you have to make sure so that and scope of services that you have to make sure fall under the FTCA coverage. So it gets very complicated. You may also hear about this 340B drug pricing, which is an extreme discount on drugs. And I mean extreme. It can be where pills are $20 a pill, $30 a pill regularly. They may be paying pennies. So it is a significant discount on drug pricing. But again, because of that significant discount, there's a big hard wall around it. So it has to be only for eligible patients that are FQHC patients. And it gets very complicated. And then there's federal loan guarantees, which can be very helpful for things like capital projects. So this is from my friend and colleague, Bobby Wunsch, where I believe Howard is at her house right now. And I love the way she presents this about the fundamentals of health centers. So the real key building blocks is there's a real belief that healthcare is a right. And health centers believe that, live that, breathe that, and that is a lot of what drives health centers. And I remember working at Lifelong, and we had to think about closing because we were getting overwhelmed and our wait times were getting too long. And so we were thinking about might have to close to new patients. The physicians, the staff, it is an extremely hard decision to do that. And we had so much pushback because everybody there had such a passion for wanting to serve the community, and it's a right to serve everyone, and we've got to figure this out. But you only had so much capacity. It's really hard decisions that health centers are having to make, but due to this kind of belief. Community control, I've talked a little bit about that. Population-based care. So I know Kaiser's amazing at doing population-based care, but health centers, that is very much about what they believe in. So you think about how is diabetes controlled among our population? How is high blood pressure controlled among our population? And they've been doing that for years and years and years, where a lot of the traditional healthcare system had not done that. So really a belief in population-based care, universal access and quality, high quality care, and I'll show some data on that. Also local economic development, and this is a really important one. Often at health centers, you want to hire from your community. So often our staff, their first jobs were at the clinics. So whether it's a front desk person or an MA or an eligibility person, we really wanted to have the community get the jobs there. And we provided a lot of economic development and supporting the community as well. Community action. So there's a lot of things that happen. Again, you got to be careful with federal funding, but there's a lot of things that happen around community action and supporting your community to have a voice. Cultural competency, very, very important, and a very important part of the hiring process and what you think about, because of, again, all of this community controlled, community-based care, et cetera, and comprehensive. So a real comprehensive set of services. So before I kind of move on, now I'm going to get into some data. Before I move on, are there any questions or anything before I move on, just about the history and the movement of community health centers?
And people can either type in the chat or you can take yourselves off of mute to pose a question. And there'll be time for questions also at the very end.
Melissa, I do have a question about how it is that some communities are more robust in developing community health clinics and centers, and other regions in the country have not has been as successful.
Yeah, I mean, I think it's a combination of things. And I'm, you know, when I think of some of the health centers that I work at, and Laura, I'd love to hear what you think about this, but when I think of some of the health centers that I worked at, they were able to come together as a community and sometimes had some external help. So I think about one health center in Oakland, La Clinica. They had students from UC Berkeley that were part of the Chicano movement that came and helped kind of community action, did some training around the community about how you get a voice, and had some ability to help them have a voice and learn about neighborhood health centers and get the funding to be able to do that. And so some were able to get some of that understanding and help around that. And then I think in other parts, it's more difficult and it's more of a challenge to come together as a community. And it's not easy sometimes becoming federally qualified health centers, some of the federal requirements. But I think it's a mix of how the community was come together, if they had some outside support, some community action. So I think it's a real difference. I don't know, Laura, do you have a thought?
I think it probably does have to do with sort of the intrinsic DNA of the community that comes together, and then also the surrounding political environment. You know, I've spent my career in the East Bay of the San Francisco Bay Area, really, you know, liberal community where there's sort of an acceptance of healthcare as a right, perhaps. So I think for us, the surrounding political environment is more in favor than it might be in other states in the country. So I think it's environmental factors and intrinsic factors.
Yeah.
Well, there are two questions that are in the chat. One is from Dr. Wynn. Can undocumented patients participate?
100%. Yeah. You do not ask for documentation.
Right.
Everyone who comes in is automatically accepted. You have to, you're not allowed to turn away. That's part of your federal requirement.
Right.
And you do have to put people on a sliding fee scale. So if somebody walks in that has, you know, a certain amount of income, even if they're not eligible for Medicaid, Medicare, don't have private insurance, don't have a variety of other insurance, you do have to put them on a sliding fee scale based on their income. And that again is a federal requirement, and how you set up that sliding fee scale and what that means all has to be done according to the federal guidelines. But they would be, if you have little or no income, you could be 100% discounted. So.
Thank you. And then from Dr. Upchurch, does the malpractice coverage apply to all providers or just the center as a whole?
It provides, this is where it gets a little complicated. It provides malpractice to every provider in the health center under their scope of services. So you have to get approval So for example, there are some health centers that have specialists there, but they have to get federal approval to have that specialty care covered under their scope of service. And for a while, volunteer physicians were not covered under FTCA, and you had to get additional coverage to cover volunteer physicians. So sometimes some health centers are like, yeah, I'm not going to have volunteers. But actually under President Obama, that was like one of the last things he did before he left, was literally change that so FTCA covered everyone. So now volunteers are covered.
Great. There are a couple more questions. Should I take them now?
Yeah, maybe let's save them to the end. I'll keep going because I want to make sure get to Laura. So I'm going to zip through some facts and figures. You guys are going to get these. You have the sources if you're really into the numbers. But I just want to, again, these are large numbers of people that are being served. So there's over 1,400 organizations with 13,000 sites serving 29 million patients. Most of the patients they serve are 91% or below 200% of the federal poverty limit, which for 200% is about $53,000 a year for a family of 4. So that's still pretty low. 100% I think is $12,000 per individual annual income. So it's federal poverty limit is very low. A big portion of the patients, 23%, are uninsured, and almost half are on Medicaid. So health centers, and I apologize, some of the data is old. This comes through the federal government. Health centers have a whole swath of data and information they have to submit to the federal government. And by the time it gets cleaned up and sent out, it can be a little bit old. But you can see, and even if you go back into the 1990s, health centers are growing, and they're continuing to grow. Even recently, there's been some new funding coming out for new health centers, and they're really growing rapidly, years to years. And you can see organizations are growing, but many organizations are creating a lot more sites. So they open new clinics, but it's under one organization. The population is very diverse, and you will see a range of population diversity depending on the health center and where it's located and how it's built up. Laura and I worked at clinics in Oakland and Berkeley, and in Oakland, California, there are 4 Fqhcs, each one serving a different neighborhood with a different ethnic profile. LA, where Howard probably knows better than me, there are 55 Fqhcs, I think, in LA County. And they are from the neighborhoods, and they've grown up, in the different neighborhoods. So you have South LA, you have Watts has a clinic, so all the different clinics, come up from the community, and each one has a different racial profile, but you can see nationally, it's a very diverse group. Again, I mentioned this, most of the population they serve are lower income. Traditionally ages, not a big Medicare population at health centers, but traditionally a lot of them were moms and kids. So you see those, the 18 to 44 and the under 18 being big percentages. 83% of patients publicly insured or uninsured. So big thing, and I'll talk about this in a minute, under the Affordable Care Act, things shifted, right, with Medicaid expansion, but still the health centers are still serving a big portion. You can see there in the dark blue at the top, they're serving a big portion of uninsured. But as you can see nationally, our uninsured rate's gone down. So health centers are serving less. So again, this is just, I wanted to show you, I don't know if you can see that blue line in the middle, the Medicaid, see the bump up? That's where ACA comes. And so you really can see that shift in the population that the health centers serve. And you can see why under Trump, it was such a big deal for health centers to be worried about ACA, because that was going to significantly change their financials, right? Because if you remember back under Medicaid, you get PPS, right? You get that prospective payment. So as your Medicaid rate goes up, you're getting more revenue. So that's a pretty significant thing. So I was just talking about revenue, and this has shifted significantly over the years. In the 70s and 80s, that Section 330 grant was a much bigger proportion of what health centers got. But now, if you look at this, you look at Medicaid, Medicare, private insurance, that's a huge portion of their revenue. And they're less dependent on grants and contracts. So what that means is now patient service revenue is the biggest thing, biggest portion of your revenue, which means how many patients you're seeing. And so that is one of these big drivers of health centers. That's why you see productivity requirements. And by the way, the feds have some productivity requirements too, how many patients you're supposed to see. They want you to see patients because they want you to be, they're paying for you to see a certain amount of patients. And so there's a lot of stuff going on around productivity, and it's a big driver of revenue. We also talked a little bit about the range of services that health centers provide. And I found this really interesting. So insurance enrollment assistance, right? Helping people get on Medicaid. Medicaid's complicated and it's paperwork and you get bounced on and off of it. It's very, very complicated. And particularly for those populations that may have low health literacy, language challenges and limited English proficiency. So enrollment assistance is huge. And I know at Lifelong and all the health centers, sometimes people would come in with their insurance papers to the member services, but they'd bring all their bills and all their other things because they couldn't understand what was happening with some of their other things that were going on at their homes. So sometimes member services would be helping with lots of different things. Case management, health literacy, transportation, I mentioned, that's a requirement. I found this really interesting, healthy foods. Health centers have done a lot around healthy foods. When you're thinking about population-based care and you have a population that may be high, a lot of diabetes in your population, they're partnering with farmers markets at their health centers, distributing food, doing cooking and nutrition. I've been to some health centers that build these new, beautiful health education rooms, and they have cooking demonstrations on how to cook healthy foods at the health centers. I also want to talk just briefly, just quality, right? So health centers, not with limited resources, having a more complex, if you look at this, you could argue that they have a more complex population. So more patients than the general population report to health centers having chronic conditions. So nationally is the blue, and health centers are the orange. And you can see more adults report having diabetes and having hypertension at health centers. Yet, when you look at the data, more health centers are able to better control that than the national average. So you're having a more complex patient population, but extremely high quality with a very challenging, limited resources, which to me is unbelievable and incredible. And health centers are very proud of this, as they should be. So I'm just going to talk about this quickly. COVID has been a huge issue for our country, for the world, and for FQHCs. So they had to close sites, they had to pivot, they had to lay off staff and furlough when, as I told you, in-person visits is a big source of their revenue. That goes away and their revenue goes away. But there was some, well, I'll mention that in a minute, but you can see here, they had to lay off staff, furlough staff, and close sites. Here's a national, you can see how many states had to, health centers in these different states had to temporarily close sites, limiting access. Big challenge for health centers, big challenge for the populations they served. So what happened? They had decreased visits, as I mentioned, so lost revenue, combined with, at the same time, increased expenses because they shifted to telehealth. I mean, pivoted. Laura can give you the direct experience, like pivoted instantaneously to be able to provide video phone visits to their patients. Extremely impressive what they were able to do. And then they had to expand services. So you're getting lost revenue, but expanding services, testing, contract tracing, vaccine management, very challenging time. But there was some federal funding that came down through HHS, the Bureau of Primary, I think they put Bureau of Primary Health Centers, that should be Bureau of Primary Healthcare, and CARES Act. Some health centers were eligible for like Paycheck Protection Program, but I'm sure you heard about on the news, that was really a nightmare to apply for. And low-income communities were less likely to get the PPP loans. So lots of complications there. The American Rescue Plan's providing some federal funding as well. So money is coming their way, but it's still a big challenge. Here's some data on the losses that were for COVID in California. But as I mentioned, they are embracing and investing in telehealth and doing some other things to save costs. They had some reserves they're spending down. They're tapping into the COVID relief funds, leveraging partnerships with others. In some cases, some of the private practices and then public health departments partnered. So really had to scramble. So I'm just going to wrap up quickly, just a little bit about what's ahead. And Laura's going to talk about this also directly from the health center perspective. But, you know, still in the midst of COVID, although they're transitioning back to in-person, as you know, this transition back to in-person in everything we're doing is a challenge. Trying to get new facility setups, thinking about how do you do all this catch-up care, right? So all these people put off care, and now you're getting a wave of people coming in to get, you know, the kids' vaccines, other things that haven't been dealt with. And obviously still working in populations and communities that are having difficulty accessing vaccines or hesitancy. And so doing a lot of education and going out and talking about vaccinations. Thinking about telehealth and what's the new normal. So they've really pivoted and really been able to expand access. But what does that mean in terms of if you do video versus in person versus calls? I know even Kaiser's struggling this. When do you do phone? When do you do video? When do you do in person? And what's the impact on quality and operations? And how do you manage that? How do you think about remote patient monitoring? So how do you think about helping people from home? How's that work? Lots of issues around social determinants of health and how COVID really highlighted racial and ethnic disparities. I had friends come to me that didn't quite understand don't work in healthcare, didn't quite understand what community health centers were and what they did. But during COVID said, oh, I get now what you're talking about with racial disparities and what that means, because it really was highlighted in COVID. Lots of issues around alternative payment models. So this issue of pay for fee for service in health centers, thinking about capitation and how do you move to real capitation like a Kaiser system. And so it doesn't matter if patients are coming in for visits for your revenue, you get a per member per month. So thinking a lot about that. Integration with the public health system, which was really spurred on through the COVID. I can go into all the leadership challenges, but lots of operational challenges and how care teams work together. And health centers are doing a lot around that because they've had difficulty recruiting physicians. So how do you get a care team around to help physicians, but also given their population health management focus, they really think about how to integrate community health workers and promotorists, those who go out into the communities and work with their communities, partnering with the physicians. And Laura can talk a lot about that. She's done a lot of work on that. And workforce, I just wanted to highlight workforce shortages. 70% of health centers said they are recruiting physicians at any one time of the year. So it's a real challenge. So your help is greatly appreciated. I'm going to leave it there. I think we'll move to Laura, but I don't know if there were any questions or we want to save those for the end. Jill, I'll leave it up to you.
Why don't we do a couple of questions and then
okay.
Move to Dr. Miller, and then we'll come back for more questions. So this is from Dr. Cohen. I keep hearing that patients cannot afford extensive lab testing. That's a barrier for patients. It seems to be dealt with differently in different FQHCs. Can you comment?
Yeah, Laura probably knows. I'm kind of forgetting about all the lab stuff now, but Laura knows a lot more. I think some health centers do labs in-house and are able to do more in-house. Some contract out. And I think depending on the lab test you need, some lab tests get much more complicated, right? You have to contract that out. And there may be copays involved. So even if you're on Medicaid, you might have a copay. If you're a sliding fee scale, you might have a copay. And so that can be challenging. And so I think it depends on the health center, what the scope is. But Laura, do you want to talk a little bit?
I would say, Melissa, you're right on. So in my experience, that hasn't been a huge problem. Payment for medication is a whole nother kettle of fish, and that is hard. But payment for lab testing, not so much. For my Medi-Cal patients, the routine labs are absolutely covered under their Medi-Cal. And then for our uninsured, there's a county program where labs are covered. So the lab testing has not been a big challenge in my setting. But again, as I say, pharmacy, absolutely. Multiple formularies, real challenges there.
And I think that's a unique thing here in California.
Perhaps, yeah.
Because in California, uninsured funds go through the county. So each county is responsible for covering their uninsured. And so in Alameda County, they cover their uninsured and cover some of these costs. In other states, they may not be covering these costs. Medicaid may not also have may have different rules and regulations in each state. So you get each county, then each state, and so that could be part of the variation too. What's covered, where you live. So that's another complication.
And this is from Dr. Winston, slightly related to this. FQHCs can provide funding through Medicaid. How do non-FQHCs with no insured patients cover the cost of care?
So non-FQHCs, right? So this is where it gets really challenging. They get paid by Medicaid, not under the prospective payment system, just under straight Medicaid. So you will hear this a lot from, and we're seeing less of it, particularly in California, but there used to be a lot more independent physician practices, 1 or 2 physicians that served a high Medicaid population in areas of need. They were not getting prospective payment system. They were getting straight Medicaid, whereas a straight Medicaid for a basic office visit might be $20. FQHC would get prospective payment for that, might get $100 for that visit. So it's a huge challenge if you're not an FQHC. However, I have worked with many physicians that say trying to become FQHCs, and it is extremely complicated because you also have to then see all the uninsured and you have to meet all those federal requirements. And many, many, many of those physicians ended up not being able to switch to FQHCs because it was too complicated. I hope I answered your question, but it is a challenge.
Thank you. We'll take one more question before moving on. This is from Dr. Menon. As clinics proliferated, has the pay structure for CEO and board members increased exponentially? This was noted in one nonprofit community hospital here in the Bay Area.
So first of all, board members are volunteers, no pay. So that one's easy. No, they haven't increased. And there is, depends on the CEO and the health center. And there are some health centers that have, I don't know, Howard's still on there. LA had some controversy here that do get high pay. But if you're running a $100 million organization, that's a complicated organization and you should be paid appropriately. However, some CEOs, so when I went and worked at at Lifelong Medical Care, the CEO there had been there for so long. I had come in from Kaiser as an administrative person at Kaiser, wanting to keep my same salary. I actually went down a little bit in salary, but I was making more than the CEO, which was silly, right? Like I was not a CEO. So some CEOs very much believe in we're not taking high pay because we're doing this for our passion. So overall, I would say majority of CEOs and health center personnel are paid. You could all, from physicians to CEO to COO, you could make more money working somewhere else in the same level of job responsibilities.
Down to the level of MAs.
If I can just add real quickly to that, this is Howard. The compensation varies a lot. You won't see the kind of compensation in just about any community clinic out of proportion the way you will in, for example, hospital systems. At the same time, they have to be market competitive to attract the staff that need to serve the people. So it's always a balancing act, as Melissa said.
Great, thank you. Wonderful. Well, I think we should move on to learn about the day in the life of an Fqhc.
Great. So Melissa, you're controlling the slides, so
yep.
We'll work together as per usual, as we've been doing for 20 years. Yeah, so I've been working in the same health center in East Oakland since 1999. And this is really reflective of my experience in one health center. There's a saying that when you've seen one health center, you've seen one health center. So some of this may be generalizable. I hope it is. And we'll just go ahead. So I've put in a couple of slides. This is from pre-pandemic times when I actually had a Saturday clinic. That got stopped with COVID and hopefully will come back. And I just put in literally snippets about the whole entire day of patients. And we won't go through every one, but I wanted to highlight a couple of things. And so the one that's in bold here is a lovely woman who's been my patient for many years. I hadn't seen her in about 5 months. She has a complex medical history, including rheumatoid arthritis, an ovarian cyst, diabetes, morbid obesity. And she also hadn't seen rheumatology in 5 years. This was really worrying to me. And I'd actually nudged her before, please, I care about you and I need you to see the rheumatologist. And the rheumatologist had told her her kidneys are bad. And she burst into tears. She didn't know what bad meant, didn't feel like it had been explained, and it was really, really challenging in a 15-minute visit. Now, some of this is primary care in general, that it's just really, people don't come in 15-minute packets of problems. But luckily, I had the records, and getting medical records from the outside is often a challenge. I'm delighted now that in my particular setting, we're on Epic and the interoperability is much better. But I was actually able to see the records. It was a creatinine of maybe 1.5, nothing, stark. And I was able to sort of just, smooth things over, talk her through it, but it was a challenging moment with everybody else. So I think that, we are, and this woman is struggling with a child with disabilities and also, intermittent employment. So really, really challenging, both medically and socially. Next slide. This is just another one, just giving you a sense of who my patients are and what's going on with them. Yeah, her COPD was bad because of local fires. And blessedly, I had 3 no-shows. But that was a fairly packed, regular old Saturday. Next slide. This is me with one of my favorite, dearest patients. You'll find most of your health centers will now have EHR. And it's, the exam rooms are going to be exam rooms. They're going to have your basic supplies. Yeah, and there's a whole team surrounding you. So support staff. Support staff and team-based care is really, really, really important. I think it's important everywhere, but especially because of the community-based feel of the health centers. It's important going in as a volunteer to really understand like, who are all these people? What are their roles here? And, where are they from and what do they do? So there's going to be front office folks. They're going to check patients in, and they'll also check eligibility. They can also be a significant source of information around various programs, helping people stay up to date on their insurance. Many of the time people will fall off Medi-Cal or Medicaid. They get their papers don't get renewed.
Orbiting me when he arrived in 1907
Whoa.
from Memphis.
Wait.
He was just the first guy to really...
Could somebody go on? Yeah, thank you. I know it's a really cool YouTube, but so front office can be it's great to know who's up there and what other programs they can help connect patients to. There will be a medical assistant. We fought hard and we finally got to a 1-to-1 ratio. It used to be 2 providers to 1 MA, and then we realized that we really needed to change that up. And again, what we strive for is a real strong dyad of MA and provider that work together, that know each other. The MA is supporting on follow-up for those patients. It really becomes a team-based panel kind of situation. The MA will room the patient, take the chief complaint, and they're also responsible for discharge instructions. In the clinic, we don't live within a unified system. Sometimes the lab might be on site, but X-ray is always off-site. Specialists are all over the area. They're not in the next building or up a floor. So the discharge instruction is really important in helping patients get things done. Referrals also are in a separate clerk will take care of that. And it's about knowing the networks. I remember early in my time, I asked my supervising physician for, well, who's the cardiologist that we should go to? And she said, who's their, what's their insurance? And I took great offense that, I was taking care of people regardless of their insurance status. And she just, told me to calm down because each insurance will have its own network of specialists. So whether it's, Medi-Cal or uninsured or perhaps an IPA, it's all going to vary. So it's a lot to learn in terms of your local environment. And then nurses, obviously, we all learned this. Nurses are the glue. They are amazing. In my setting, they do obviously a lot of phone triage, some patient education, and linkages for complex case management, complex patients. Amazing. Next slide. Melissa talked about all of the different services that are available at the health centers. We really do, and you saw this with the health center movement, there's a real sense of wanting to take care of the whole patient. So in my particular setting, we have podiatry on site, we have access to dental, and we've made a really strong effort for integrated behavioral health. So again, this is about where I work, where lifelong, but most of our sites have access to behavioral health on site. This is primarily staffed with licensed clinical social workers. We also have a program with the county where there are integrated behavioral health care coordinators. They're essentially CHWs who are working to link patients with resources for behavioral health. Sometimes those needs can be taken care of in the clinic. Sometimes we have to link out to network, mental health network or county resources. In many places, the serious mental illness is carved out to the county. So that's always a challenge, but we try to know the local resources and make it work. And again, referrals are made to the outside. And it's challenging. It's an incredibly fractured system. It's very hard to figure out what's going on with a patient if their mental health care gets carved to the outside. That's why we, over the years that I've been at Lifelong, which is now 22 22 years, we've really seen a beautiful growth of the integration of behavioral health. And for me as a primary care provider, I love it. If I can see the notes of the therapist that's integrated right into my EHR, I can do so much better for my patient. Referrals. I alluded to this a little bit earlier. Really, what the network that you have access to for your patient depends on their insurance. So it really is learning the local environment. We rarely specify an exact practitioner. The referral clerk tends to know the network. And in general, they'll send the note, they'll send a cover sheet that has your consult question. One of the things that I've been working on for a long time within our network is how do we support our younger clinicians and our advanced practice providers in how to write a good consult, how to ask a good question, and how to do an appropriate, thorough workup prior. So that's an ongoing challenge for us. But the key consult question is very, very important. And referrals clerks are glue. They really hold it all together, and they know those networks often better than I, because things can change so rapidly. Next. So challenges patients face, and I think these are probably universal. They stem from my experience in East Oakland, but I think they will be front and center and present in many of your settings. Transportation. People often do not have reliable transportation. The car might be broken. They do not have money for Lyft or Uber. Interestingly, my 23-year-old son is now a medical assistant at my clinic. And the other day he was setting up a Lyft app for a patient, and it didn't work, and this and that. And he called her niece to see if the niece could, help with the money for Lyft. And she said, I'm sorry, but it's the end of the month. And my privileged child looked at me and said, Mom, month to month is really real. And I'm like, yes, honey, month to month is real.
I didn't get to, hold on a second. I was on a video and I just am like, okay, yeah.
Got it. Okay, thanks. So transportation is incredibly challenging.
So anyhow, what was I going to say?
Can the person who's chatting go on mute?
I said,
can everyone mute?
Let's see here. Hold on.
No, I don't want it from.
Great. I think we got that. Okay. And hold on, Laura.
Okay. I just unmuted myself.
Okay, great. You're good.
Okay. Am I good? Okay. Awesome. So transportation is really challenging. Economic challenges. Yes, month to month is real. Housing. It can be inadequate, stress related to housing insecurity. A lot of people are couch surfing. Of course, in the Bay Area, the price of housing is horrendous, and we've really had a lot of out-migration. People are leaving the Bay Area, going further out into the Central Valley to live, and sometimes they'll even commute back into the Bay Area for healthcare. And you always have to ask about access to refrigeration. For meds that need to be refrigerated, it's not a slam dunk that the fridge is working. Food, always an issue. Lack of access to healthy food. I remember reading a really poignant article years ago about how at the end of the month, people are really in deficit, both caloric and sort of psychological deficit. So when the new money comes at the beginning of the month, there's spend on foods that are not as good for you, but they pack a lot of concentrated sugars because there's been sort of a deprivation state. So lack of access to healthy food as well as hunger. And we've done a lot with food programs, very much so. Food as medicine is really very important. And then trauma. I remember being just so struck by the resilience of my patients in East Oakland, but also the traumas that they face. Family conflict that stems from the external pressures of, inadequate housing, inadequate food, inadequate income, physical violence, both interpersonal and then, street violence, and systemic. The majority of my patients are African American, and they're, you know, living in a toxic system. We're all living in a racially toxic system. So people have been up against prejudice and challenges and barriers since before they were born. And it takes a huge toll. I think we're really understanding that now, at least I am, in a way that I know I was not taught about. And then stress, clearly stress secondary to all of the above things. And then of course you throw in COVID and you throw in racial reckoning. Next slide. And then you throw in COVID. Yeah, so the COVID bomb that fell into our lives. Melissa talked about this to some extent. And everybody in healthcare has gone through hell and back. And what I want to share with you is really sort of the Fqhc flavor of what that was like for us. Next slide. So what was it like? Lord, everything changed. I mean, I remember early on in March and April, just having weekend meetings, long Saturdays with my CMO colleagues, trying to just brainstorm and hive mind, what were we going to do about workflows? How were we going to divide clinic spaces? You know, you needed a clean space for prenatal and babies. You needed a respiratory tent. You know, all of those things. Had to completely revise workflows, had to get some staff home. A lot of staff didn't have laptops to work from home. I had an old funky lifelong laptop that I'd gotten probably in the year 2000 and something, 2010. I took it back. I didn't need it anymore. And I took it back so somebody else could have a laptop to be able to work from home if their job did not require them to be there. We set up new systems for telehealth. A lot of us ended up using Doximity Dialer. One of our health centers used FaceTime, and they didn't want to do FaceTime on the provider personal phones, so they bought iPhones so that you could FaceTime from a company phone, if you will. How do you do handoffs and within clinic if everybody's working off site? I remember when one of my fellow CMOs said, you know, oh, you can bubble chat within Epic. And I was like, bubble what? You know, we had to learn, you know, all these modalities in Epic that we didn't necessarily use before. And in fact, my health center had just gone up on Epic in January of 2020, and the last health center to go live with Epic, La Clinica, went up in April of 2020. They had been prepping and they decided they would just go ahead and do it because there was no reason not to. But I mean, going live on Epic in a pandemic is nothing short of heroic. Again, how do you do team-based care? How do you support patients on all of this technology? You know, the phone calls, very hard to get used to for patients and staff. And frankly, I still have challenges with video visits. It means that somebody needs to instruct my patient that they're going to get a text. They click on the text, and I use Doximity Dialer. And a lot of times my patients don't have strong internet access. I've had so many dropped video calls, and it's really, really challenging. And then how do you do paperwork, right? If all your providers are doing telehealth remotely, who's signing off on all the forms? And sometimes we manage something like DocuSign, and oftentimes there was, you know, one provider a day physically present, and they would have to do all the signatures. But we're managing. I mean, it was all, I often say community health centers are held together with spit and duct tape, and we did it. we held it together. Next. Not to mention all the other things. So, you know, all of us were in this boat, but, you know, learning about COVID, what are, you know, a new and emerging disease. Is it droplet spread? Is it not? What do we do about surfaces? How do we educate everybody about surfaces? How do you figure out space allocation? You know, work from home, staff impact. getting staff tested. That's absolutely challenging. One of the things that Melissa mentioned early is oftentimes staff absolutely comes from the community. So one of our health centers, La Clinica in the Fruitvale, was incredibly hard hit. The Fruitvale neighborhood was a hot spot in Oakland. And so not only were patients sick in large numbers, but patients are actually family members of staff members who were getting sick. So dealing with staff shortages secondary to COVID. Everybody had it, but we had tremendous testing challenges. Just getting test kits was incredible. I often say the first night I slept well in pandemic times was the night of April 10th, 2020, when we got 1,000 test kits from UCSF, because I'd been doling out dribs and drabs of test kits to the health centers on a population proportional basis. And then we finally, the CZ Bio Hub at UCSF came through. And then I could sleep. We've done contact tracing. That's work that was never really part of our system here. Our health centers often had very little contact with the public health department here in Alameda County, and that's completely changed. Our health centers got contracts for testing, then contracts for contact tracing, and now contracts for vaccines. So there's a real interrelationship that's never really happened before. And again, absolutely the disparate impact on communities of color. Melissa was alluding to this as well. You know, she and I have lived and breathed healthcare disparities in communities of color because that's where we've worked. And now I think that's much better understood because of the disparate impact of COVID. Racial disparities in healthcare really made front page news. And I think there's much more of a conversation about it. Very important. Of course, vaccine shortage. This is an old slide. We're not in vaccine shortage anymore. We're actually in glut. But I think one of the things that is very, very clear in my setting is vaccine hesitancy. There's a definite mistrust of the healthcare system. And I think that's something that you'll see that thread all the way through as we talk about, you know, the health centers rising from community, because the rich doctors who live up on the hill aren't treating us well. So we're going to figure it out for ourselves. There's been a long history, and we know, of maltreatment of people of color by the medical system. And it shows itself now with people saying, I'm gonna wait on this vaccine. Y'all made it too fast. You know, you didn't test it enough. I've heard about the complications. I don't wanna go there. There's an amazing book called Medical Apartheid, which is a history of medical mistreatment of African-American communities in the US. And there's a piece in there that really struck me about how sort of oral history about this maltreatment is passed down through, you know, kitchen tables over the generations. And one of the things that people say is they don't want to be treated like a guinea pig. I've heard that in East Oakland for 20 years, and now I understand better the history that links to. So I think, you know, we've gone through the easy vaccination of the 80%, and now we're into the really important and nuanced conversations with the next 20% of people who we want to vaccinate, and they have a lot of questions. And again, all of this in a time of racial reckoning, with huge impacts on our communities and staff. You know, my clinic in East Oakland still has plywood over the windows because of, you know, concern about unrest last summer. But those plywood coverings are painted with beautiful murals. And it's really sort of emblematic of the community that I've worked in and their resilience. Next slide. That's it. Questions?
Wonderful, Dr. Miller. Thank you so much. Melissa, I'll have you stop the share. And we have a number of great questions. So what we'll do is we'll try to get through as many as we can so we can get on the recording. And then once we get to the bottom of the hour, if there's still other questions, perhaps I can email them to Melissa and Laura, and I can forward them via email. So let me go ahead and get back up to some of the questions here. Give me just a moment. Great. What percentage of health center provider staffing is comprised of nurse practitioners, physician's assistants, and MDs? And do these percentages differ from traditional FFS practices, academic practices, hospital-based practices, et cetera? This is from Dr. Winston.
Yeah, I mean, I can take that. And then Melissa, you probably have stats at your fingertips. When you've seen one health center, you've seen one health center. So it does vary a lot. I would say that certainly it's, maybe 50-50 MD to advanced practice provider. It's sort of oftentimes the health centers are training grounds for new grads, and that includes people at all levels, both advanced practice, MDs just out of residency, as well as support staff. Just as we've seen a real challenge with workforce at the provider level, we also really see it at the support staff level. And I've spent months on end mentoring new grads to have them stay 2 years and move on. One of our health centers, Asian Health Services, really has a very high percentage of MDs, whereas others are much heavier on the advanced practice provider front. So it really varies.
And I just add to that, it varies state by state. A lot of the regulations about oversight of advanced practice, I think California has some pretty strict. I've worked at rural clinics in Arizona where they had clinics primarily staffed with advanced practice. So like 80% advanced practice and 20% physicians, MDs overseeing that practice because it was a different oversight requirements. And so I think that also makes a difference state to state. And we're in California, there's some changes going on now too, regulatory wise about advanced practice. So I think it's shifting.
With the Bay Area clinics, are there programs within the clinics, whether they're formalized or not formalized, for kind of integrating and training the new nurse practitioners if they've just come out of residency?
Yes, in fact, Lifelong has an NP residency, which is really cool. It's been going on for like 5 years now, and it actually involves several of our health centers. It varies by clinic. You've seen one health center, you've seen one health center, but in my experience, NPs are ramped up a little bit. They don't start off with a full schedule of seeing, 11 per 4-hour session, 11 patients. They start off with a slower schedule. We used to, and I don't know what the status now, but we built in mentoring time. There's chart review, things like that, but it will vary. It will absolutely vary from place to place.
And there's also, as an FQHC, you have federal requirements, as I mentioned, productivity requirements for a physician, and it's less for advanced practice. So if you get a really experienced advanced practitioner who can see as many patients sometimes as a MD or close to it, that ends up being kind of advantageous because then you can have your MDs see a little bit less and maybe mentor more. So there's some federal regulations around that also impact.
Great, thank you. This is a comment from Dr. Norris up in Washington. With regard to workforce shortages, especially of primary care physicians, a number of FQHCs are working with local academic partners to create family medicine residencies based in their clinics.
Yepper. And in fact, Lifelong has its very own family medicine residency, which is in its first year. It's very exciting. Yes, I think, sort of like grow your own is a really, really great idea. And some are absolutely doing that.
Yeah, and you see the range of being practice sites so partnering with a residency program and being a rotation site, to having, there is a federal program to fund health centers to become residency programs. So, but it is extremely complicated, as it is for anyone to become a residency program. And but there's a lot of work happening around that, because there is a I mean, Kaiser has a hard time hiring primary care physicians. So there's a shortage in California. We know for sure, tons of data on that. And I know that's around the country, so.
Thank you. From Dr. Winston, any data regarding percentage of patients in healthcare centers with substance abuse disorders and how these numbers compare to other healthcare delivery systems? Do centers universally provide substance abuse support and interventions?
Data-wise, I don't know. Melissa, do you have light to shine on that comparison?
I don't have it at that. I know that there's been a lot of looking at this, and I know there's been a lot of work around. And Laura, do you guys do stuff with MAT treatment?
Absolutely,
and,
yeah.
You know, I think that a lot of the health centers,
push.
I like a lot of the health centers, and it depends on the health centers, because some health centers get SAMHSA, I'm trying to remember what that is, federal government, but substance abuse funding. And so some health centers are big providers and do that. And some health centers, there's a health center in San Francisco, Health Right 360, which actually started as a inpatient substance abuse treatment center and then evolved into Fqhc. So I talked about how some of these health centers have evolved from various different places. The one I mentioned about migrant workers, well, this one really started with substance abuse treatment and that population as its core population, and grew to then be a full medical care facility beyond just substance abuse treatment. So that health center has a huge portion. So it does vary health center by health center, but I know that there is a work and funding happening across Fqhcs.
Mm-hmm. Yeah, and we did a lot of work in our network trying to really increase capacity for medication-assisted treatment, the MAT. So yes, it's there. Again, you need to ask in your local environment, you know, what is the status, but certainly that's part of our services.
Thank you. From Dr. Menon, do clinics obtain patient satisfaction surveys? What health indices parameters are collected to evaluate clinics' efficiency?
So many surveys.
Surveyed to death. Actually. It's federal requirement. So there is a system called Uniform Data System, UDS. I'm happy to provide the link to that. You can actually look health center by health center on all kinds of quality indicators, number of patients. That's actually publicly available information. And part of that is patient satisfaction. And you have to do patient satisfaction surveys at least annually. And I will tell you, among health centers, patient satisfaction and patient experience is rated extremely high. So I actually struggled with this a lot. So our patients were so thankful to come. We would get 97, 98, 99% satisfaction rate when I knew they were having to wait 2 hours or 3 hours in the waiting room. And so we actually shifted to patient experience so that we asked, are you satisfied with the wait? Everyone's like, yeah, you're seeing us. We're so happy that you're seeing us. It doesn't matter how long we have to wait. Versus I started doing, how long was your wait, as opposed to so that I could start, because I knew that wasn't right. And I wanted to see a change from 3 hours down to an hour, right? So rather than getting 99% satisfaction, I wanted to see something that was, for me, was actionable. So you're seeing a lot of health centers becoming much more sophisticated around patient experience. And there's a lot of work right now happening around patient experience with telehealth. How is the switch to video being? How is your care? Much like Kaiser does, right? Would you have rather done video or phone or in person, right? So you're getting very sophisticated patient satisfaction and patient experience surveys. And there's CAPS, there's some national surveys tested, you know, so that you can do benchmarking and comparisons. Health centers spend a lot of time on this, and it's very important for them. And they spend a lot of time at their board meetings because their patients are on their boards. so they can hear directly from their boards how the patient experience is like. So yeah, there's a lot of data, and I'm happy to, if maybe Jill or Jean, you guys send me an email, remind me to send I can follow up with some of that. And you can get UDS and look by state and by county and by site.
Great, thank you. Some FQHCs partner with larger healthcare organizations, for example, Kaiser and La Clinica, or academic medical centers and training programs for resource sharing for part of the training experience. Can you comment any more? I know we talked a little bit about the residency, but comment any more about that?
Yeah, I mean, it definitely, I feel like in my role at East Oakland, when I was the associate medical director there, it felt like I was I had students coming at me, you know, every which way, because people really, really, really want training sites. So that's definitely a part of the work that we do. In my particular setting, it was residents, internal medicine residents from Alameda Health System, NP students from UCSF, NP students from Samuel Merritt, local university. So really, that is a part of what we do.
And I will say there's a lot of partnerships happening and innovative partnerships happening in terms of other healthcare providers. So you mentioned Kaiser or UCSF, and I know there's clinics that are sometimes partnered with a hospital, a public hospital in other states, at a public hospital where the clinic might be the outpatient setting, and there's referrals that happen back and forth. I will tell you though that it gets super complicated because of the FQHC regulations and the access to things like PPS and 340B. There's these super hard walls that you put around it. And so there are FQHC special lawyers who help you figure that, right, like specialize in these contracts because it's very complicated. But you're also seeing Lifelong has supportive housing programs where they have clinics in low-income housing units. So you're seeing housing advocates and FQHCs partner together. You're seeing, you know, food justice programs. You're seeing all kinds of social programs also partnering. So it's healthcare providers, but the broad range of public health also partnering as well. It just, the healthcare provider partnerships can get complicated, but health centers are doing it and working and trying to do it.
Mm-hmm. Absolutely.
To what extent do the clinics offer opportunities for ongoing learning and CME for their clinicians? And then I know we touched a little bit on mentoring, but can you comment on any in-house mentoring that occurs?
I think in-house mentoring happens all day, every day. And that was perhaps one of the casualties of telehealth, is everybody was in their living rooms or their bedrooms or whatever. And we weren't able to have that, you know, provider room, oh my Lord, help me out moments. You know, people tried to they set up Zoom rooms, things like that. In my experience, the health center has, Lifelong has a CME, what is it called? Dividend. It's money, pot of money that you get access to. We actually got a health center subscription to UpToDate.com that we could just had free access to for all of that support. So there's CME money that can go for any kind of CME program. My organization, CHCN, does free CME for providers that really tries to be responsive to what the needs are.
Yeah. And I think in the workforce challenges, they try to be as competitive as they possibly can and try to be creative. So sometimes you can't often salary, but I think all health centers will provide CME for their physicians for sure. And then there's these advocacy groups that happen for health centers. So there's a county advocacy group, which is Alameda Health Consortium, which is health centers come together to advocate to the county. There's a statewide. In every state. California Primary Care Association represents all FQHCs in California, and then NAC, National Association of Community Health Centers, represents all community health centers, FQHCs in the country. They advocate to the policymakers and advocate on behalf of health centers, and they also provide all of those places provide free CME as well. So there's tons of education opportunities and webinars. Health centers are amazing in that they come together I'm working with them on telehealth now. We have a library of resources of workflows that everybody puts their workflow, and you can pull it and try to use it in your health center. So, I mean, health centers are amazing in that they're all trying to better each other in most cases.
Yeah.
I think sometimes you might see, but that's in the vast majority, people are working together. And so CME and helping each other. You see site visits happen between, like if one health center is doing something really innovative, other health centers go visit. So I think there's a lot of education and mentoring.
And that frankly was on steroids with COVID. On steroids, just incredible. I mean, I sourced wrote a protocol workflow on outdoor COVID testing based off of YouTube videos, and got, you know, my pal CMO at another health center to look at it with me, and we gave it to everybody. Boom, done. 4 hours, boom. March 2020, done.
Amazing. Dr. Miller, can you comment on the average amount of time that it would take for a patient to see a specialist once a referral is placed by a referral?
Oh, Lord have
and
mercy.
also the communication back to the referring provider.
Yeah, it is variable. It depends on insurance. It depends on the network that the patient is going into. So it's very hard to say. The best person to ask is the referrals clerk, who will know what likely wait times are. And then there's this thing, it's called pick up the phone. And you call that doc and you say, I have a person who really needs to be seen. Please, doc to doc, help me. So it very much depends. I do think though that is, you know, we're old, right? And we remember, you know, really knowing our colleagues and elbow to elbow relationships in hospitals. The young ones don't. They're sort of referring out into the void. So, you know, it takes some extra effort to pick up the phone and call a colleague, but that's how you build those relationships that we don't get elbow to elbow in the hospital anymore. So asking the referrals clerk, picking up the phone, and then, you know, how the messages get back again is going to be very local. I am lucky to now live in an Epic world where I can, you know, just look and see what's there and care everywhere. I tell this story, I literally cried the first time I was in Epic and I was doing my chart prep and I looked at a patient and saw that she'd seen neuro 2 days prior and I didn't have to ask anybody to get me the records. I was crying at my kitchen table because she finally got to neuro and I could see his note. You know, otherwise it's what I've done for the 20 years prior, which is, oh, you saw Dr. Richardson. Okay, let me see if I can, you know, let me give a message to medical records and see if they can get it faxed over. You know, and sometimes the specialist will send the note appropriately and it gets faxed or mailed or whatever. But it was really hit or miss.
Great, thank you so much. Well, we are already at an hour and a half. This has just flown by. Terrific questions from our physician volunteers from the Maven project, and there are actually many, many more that were there. A really big thank you both to Melissa Schoen and Dr. Laura Miller. This was an excellent presentation. This was just spot on, perfect for all of us to get more educated about the FQHCs and the providers that we are serving at the Maven project. Howard, I don't know if you're still on, if you had any closing comment.
Thanks, I am still on. And I'll just take a second to say one of the key things you heard during the presentation was if you've seen one FQHC, you've seen one FQHC. That's even more the case with the free and charitable clinics. So the FQHCs are privileged in comparison to the free and charitable clinics, which are running on nothing very often. And I think it would be great to follow up at some point with a separate presentation, Jill, for our volunteers on the situations that they face, and especially most commonly, they are in states that are red states and have rejected moving forward with Medicaid expansion. So they've got a kind of double whammy too. So hold on to your seats for any discussion of that, because that's super challenged. And the last thing I'll say is, in terms of referrals, that last subject, it's unbelievable how long the waits can be for places that are even located next to major metropolitan areas and major TT institutions, and the waits can still be months to get specialist referrals. So everybody struggles with that one way or another, and they have to rely on those personal relationships. And thanks to you both and to Jeannie for organizing this. Thanks so much.
That's great. And it's wonderful that the Maven project actually does amazing things to help fill that void in terms of wait times and referral times and mentoring and education. So once again, a huge thank you for everyone for coming today. I will be able to share the slides with you all, and then this talk is being recorded, and I'll also share with you the link to the recording. It'll probably take about a week or two for that, and we'll share that with all the volunteers, even if they were not able to attend. So I hope everyone has a wonderful weekend, and thank you all for what you do for your patients and the providers.